So Neil and I are going to talk with you about the work group that is putting together a perspectives paper on the lessons learned from COVID. And we've been conceptualizing this paper for a while and hope that today's discussion will also inform some additional changes that we might make to it. But just to review for you, and if you can go to the next slide, please. This is a highlight of the rationale for the paper and what we're hoping to achieve in terms of the contents, and I'll go over the outline with you in just a moment. But we thought it was really important to focus on lessons learned and initially also be able to reflect on the 2019 consensus study model, which Neil's going to go through with you in just a few minutes. But we know that the context of understanding how to address well-being was really laid out in that model and in the consensus study. But unfortunately, many of the recommendations never really were put to action because the pandemic occurred and really thwarted many of those efforts. Because as everyone in this call knows, we'd begun to really focus on how do we address well-being, how do we put mitigating and reduction factors in for burnout long before the pandemic. And as has been mentioned already, the acceleration of the effects of the pandemic on burnout, on moral distress, moral injury, and all different aspects of stress injury and affecting mental health, and many other aspects such as the disparate impacts on minority populations, as well as the effect on women, are things that everyone has lived through. And so we want to be able to humanize this experience. We want to be able to stress that there were many threats, but that also as we walk through the events that occurred over time, we saw them changing. And so there were different factors that were driving reduction of well-being, where at the same time, we know that the actions that really need to be taken are definitely informed by these changes and how society had reacted. You know, as we've mentioned, things like misinformation, as we looked at the change from illness and fear to vaccine and hope, and then again, a number of other mitigating factors. So ultimately, what we want to be able to do with this paper is capture the human experience, to be able to talk about the threats, to talk about the solutions, to recognize that as the pandemic changed effects, not only with the disease, but also in the workforce and other challenges, but also with the end goal of making sure that what we continue to stress is how do we have well-being as a value within our organizations, so that we're helping all workers and ultimately helping patients. So just a brief review. We did have extensive literature review, some of which is actually still ongoing for the peer-reviewed literature, as well as the gray literature. And we think this is important because so many experiences and outcomes of the pandemic really didn't have time to be evaluated in the typical way we would see with peer-reviewed literature. As I mentioned, we're going to do a chronology of the effects of the pandemic with different milestones, the different effects of stress injury, looking at other factors such as the advent of vaccination, the prioritization of healthcare workers, and then of course we know the variants that cause different effects, and also the issues like vaccine hesitancy and the ultimate downside in terms of public sentiment that created situations of violence against a variety of healthcare workers. So we will move through those and again really highlight not just the drivers, but then what have been the effects, and then how have we addressed them? What were the solutions, both immediate, short-term, and long-term, so that we can again identify how have we begun to tailor solutions that will support our workforce. And where I think today's conversation has been incredibly helpful is again recognizing there are some clear themes that go beyond the compendium that we can begin to identify in terms of how do we emerge from pandemic to endemic, but also keep our primary focus of recognizing that we must have long-term sustainable solutions in order to be able to have more well-being, and to stress what we should not forget that we experienced throughout this pandemic, the challenges that we'll see in terms of changing culture, but also making sure that we do not let up on any of these efforts. So I'm going to turn it over to Neil, who's going to walk through the well-being systems model, and again, how the pandemic has informed and accelerated and exacerbated the effects that really require action now and into the future.
Thanks. So if you could go on to the next slide. So I want to just thank Pam, Tim, who co-lead this working group with me, and all the members of the working group and the staff who put this magnificent effort on. It was just eye-opening, and to coin a phrase, it's like drinking from a fire hose, all the great ideas that came out. The 2019 clinician well-being systems model shown here served as a guide to developing the consensus studies recommendations, because we want to take a systems approach to well-being and burnout. It conceptualized burnout as job demands exceeding job resources. These work system factors are influenced by frontline care delivery processes, healthcare organizations, and the external environment. Individual clinicians' characteristics and support systems mediate how work system imbalances determine their degree of well-being. While the core features are still relevant and important, COVID adds new considerations. Many were discussed earlier today. Elements affected by COVID are marked with red triangles on this slide, and you can see that there are 5 of them. We'll highlight how they need to be incorporated into the model, because updating the model can help us develop solutions to better address current and future needs. Work system factors, which are at the core of the well-being model, job demands and job resources, were transformed. We went into crisis mode due to the public health emergency, so the timeline for everything was accelerated, and there was an abrupt shift in priorities. Staff and equipment shortages increased work for those who remained and impeded high-quality patient care. Inadequate, scarce, uncomfortable PPE degraded provider safety. In the conceptual model, we talked about high-tech things like EHR. This was low-tech that turned out to be the rate-determining step. Moral distress increased along multiple dimensions with different issues in different phases of the pandemic. Patient factors not previously considered affected care, including different belief systems and profound differences in opinions on how to prevent or treat COVID. Stress arose from attempts to balance the needs for patient care and productivity versus clinician safety. Disputes about hazard pay arose. There were challenges to autonomy stemming from assignment of healthcare workers to unfamiliar clinical roles. PPE and social distancing interfered with professional relationships and social supports. There were new work-life integration challenges, for example, concerns about bringing COVID home to your loved ones. Individual mediating factors became more focused on health. There was fear of getting COVID, problems associated with the acute illness if it was contracted, and symptoms associated with post-acute COVID syndrome. We never thought of this type of health in the individual mediating factors in the conceptual model. Personal relationships and social supports were eroded by the need for isolation and quarantine. Basic needs for rest, shelter, health, food, etc., were challenged as never before. The 3 concentric circles, the 3 levels of systems that influence work factors, were also shaped by the public health emergency, the need to respond to it, and other societal trends. Previously underestimated factors in the external environment are now recognized as key contributors. Changes in individual priorities and the economy led to the Great Resignation. Social and economic disparities, bias, and lack of diversity, equity, and inclusion are potent determinants of individual and population health, well-being, and workplace success. Societal divisions deepened, fragmenting responses to the pandemic. Some view the values of individual freedom and social responsibility as conflicting rather than complementary. Mistrust of government authority and the scientific method is widespread. Medical misinformation can be disseminated rapidly via social media. There's erosion of trust and respect between the public and healthcare workers. These are things that we just didn't think about before. On a positive note, measures to address the pandemic, bias, and social and economic injustice and misinformation were enacted. Rules and regulations were relaxed that reduced administrative burden and enabled telehealth to flourish. Healthcare organization responses to COVID varied. There was a breakdown of just-in-time production, reshaping the supply chain. There were challenges in communicating rapidly changing guidelines. Healthcare organizations sometimes had difficulty balancing the need for productivity with their workers' needs, leading to mismatched values and incentives and lack of mutual trust. On the other hand, some organizations met employees where they were and supported their needs in novel ways. They formed new high-functioning teams and processes with goals to promote transparency, trust, and well-being, and reduce barriers to providing care. Frontline staff shortages varied moment by moment. unanticipated resource shortages interfered with clinician well-being and patient care. There were frequent changes of hospital unit types to meet staffing needs. The rapid introduction of telehealth was disorienting for some patients and providers. Some healthcare workers could perform their jobs remotely, but others could not, which exacerbated inequities even when vaccines were available. There were disruptions in training for all types of learners. However, work for many became more meaningful and new connections were formed, at least partially mitigating burnout and promoting teamwork with a shared mission. If we do this right, our revised model will assist us in developing effective solutions for current and future threats to clinician well-being by identifying challenges and opportunities. As the Action Collaborative has stated from its inception, clinician well-being is essential for safe, high-quality patient care. And thank you for your attention.
We're coming up on the last few minutes of our meeting this afternoon, an incredible afternoon, very powerful. Starting with Art Henger's opening remarks, one of the things that impressed me is that it's the power of personal stories. And I was struck throughout the day's sessions by how many of us shared personal stories, which really brought all these issues to life. I neglected to introduce myself. I'm Darrell Kirch, President Emeritus of the Association of American Medical Colleges, and a former medical school dean, actually, at 2 different medical schools. And I realize now, I didn't earlier in my career, that these personal stories are probably the best weapon that we have to combat stigma, which is such a powerful and corrosive element in all of this. For decades, I never talked about my own experience with becoming burned out as a medical student, and also my own experience at the very short path that can exist between being burned out and developing other forms of distress and illness, including anxiety disorders, depression, things I suffered from. And one of my biggest regrets in life, talking about personal stories, is that in my time as a dean, I welcomed 13 different classes of medical students to their careers in medicine. And I never shared the experience I just mentioned to you. We lost students to suicide. We had students leave medical school and careers in medicine because of their burnout and other forms of distress. So I just wanted to underscore that a lot of the power of today's discussion really lies in our willingness to be honest about our internal experiences and to reach out to one another to share the impact of those experiences and support one another. The next thing I wanted to mention that I think about a lot is this session very, very appropriately has focused on the impact of COVID-19. But we should never lose sight of the bigger picture fact that burnout and other forms of distress have been with clinicians probably forever. And that we had this potent culture of silence, a culture of silence that I think was reinforced often by the stigma that so many of us have mentioned today. Over the last 5 to 10 years, this problem, I believe, is finally fully coming out of the shadows. And I want to give due credit to Dr. Zhao, the National Academy of Medicine, and to all of you, because really all the participants in this call I view as real leaders in bringing this problem out into the open so that we can finally discuss it in the ways it needs to be discussed. So the pandemic has certainly deepened our problems. The pandemic combined with demographic shifts is leaving us in a real workforce crisis. That is truly tragic, but it also creates an opportunity for us to continue this effort to bring these problems out into the open and to honestly talk about them. I think that one of the most striking things about the presentations from the institutions today was that we all know that our healthcare system suffers from being very fragmented, and it's filled with fracture lines. And some of the most effective strategies to combat burnout and related forms of clinician distress have involved bridging those fracture lines. You know, sometimes the fracture lines are between disciplines. Sometimes the fracture lines are between frontline workers and people in the C-suite. Sometimes they're between independent corporate entities that sit side by side in the healthcare system. But the efforts that seem to be bearing the most fruit bridge those fracture lines freely and create a sense of common purpose. The idea that there needs to be a shared organizational or system value around well-being was the strongest vote getter. So in sum, I think this crisis in clinician well-being is one of our nation's biggest grand challenges right now. As such, as Dr. Zhao mentioned earlier, as a national crisis, as a grand challenge, it requires a national strategy. And that is the convergence right now of the work all of the organizations here today have been doing and the work the National Academies Collaborative is doing. We hope to really coalesce all these efforts into a crystal clear national strategy that drives that number. People who say my organization has well-being as a shared organizational value, to drive that number higher. That national strategy needs to focus on the individuals and the things they can do, things like peer-to-peer support. It needs to focus on the organizations, but it also needs to focus on things that national entities can do. And I hope it isn't lost on anybody what a powerful statement it is to have the Surgeon General cross all the hurdles he had to cross in order to actually be a co-chair of this initiative with the National Academy of Medicine, to have organizations like CDC, NIOSH, and other federal entities involved in this. That underscores the national nature of this imperative. I just want to finish by thanking the folks at Froedtert Health System, MCW, the group from New Orleans at LCMC, the folks from New York at Montefiore, for taking time out. You know, they're on the front lines and they took time out to really help put this all together. Similarly, thank the National Academy staff for this. And obviously, special thanks to the planning committee. That makes it fitting for me to turn things back for the last word to Tim Brigham, who was a key member, leader of the planning committee. So Tim, you can close us out.
Thanks, Darrell. Thank you very much. I am Tim Brigham from the ACGME, and I had the privilege of working with an extraordinary group of people, not leading, but facilitating and helping the group come up with what I think was an extraordinary day, extraordinary conference here. And before I go into the non-religious benediction piece that I will give you, I really do, there's a lot of people here to thank. Dr. Kirch just gave thank yous to the participants, and all the participants were, I mean, the people on the panels and the speakers and facilitators, et cetera. But another group, because what we did here was we created a community. We created a community under the auspices of the National Academy of Medicine. And I think everybody here, I thank everybody who stayed here and went through all of today. What you contributed to the effort and to each other is extraordinary. I mean, just extraordinary. But the most extraordinary, if I wish I had a different word, they gave that we really need to thank, who pulled this together in ways that those of you who weren't watching couldn't see. They gave their hearts and their souls to this. And that's 3 people on the NAM staff. And I would really like it. I can't see everybody, but if you unmute yourself and give, give a real whoop to these 3 people, let me give the names. Thuan Tran, give her a huge round of applause to her. Kimber Bogart and Catherine Colgan. They are extraordinary. And I wondered if we were burning them out, but the fire that was lit by this collaborative and what came here fueled them to such a degree, and they gave so much and did so much for this. It's extraordinary. And so here's where I'll go. I mean, over the last 2 years, we've all worked and walked through a long and dark and cold journey, often scary, frustrating, sometimes infuriating, and more often lonely. It's been hard to keep going sometime. It's like winter came and never left, it stayed. And the fire in most of our hearts and our hearts started to sputter and grow cold and dimmed. And people felt overwhelmed, drained of strength. Nobody really understood. One of the things that happened during this COVID experience, as Dr. Kirch just said, is we began to hear voices, small, then louder and louder and louder, voices and cries and pleas that something has to be done. Something has to be done. So it's really symbolic and metaphorical that we had this webinar, this conference at this time of year, because in 5 days, we observe the spring equinox, which for a millennium in cultures and religions across the world, it's been celebrated because it symbolizes something really, 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 to use a technical term, cool. Rebirth, new beginnings, redemption, starting over, that anything and everything is possible. We had 4 goals to this meeting when we started: to raise the visibility of the effort, to improve understanding, to discover new solutions. And now, as we end, we've realized those 3 goals. The 4th goal, as we turn our face to going back to work after this, is where we're going at this point. Anything and everything is possible. The 4th goal is we laid the foundation for the long-term journey that we're all going to be taking individually, organizationally, and nationally. And we did it in the context that was so beautiful. It started and ended, and throughout, it was a thread throughout. We heard a story from Art, and we heard a story from Darrell that was incredibly meaningful. I don't know if you're watching a chat, but there's barely 87 people in the room, and there's 87 comments in here that responded to that. And what I'm reminded of is a comment from Viktor Frankl that was a thread throughout this, as he wrote of his experiences in the horrors of a concentration camp, of a Nazi concentration camp. What is human is still valid. What is human is still valid. That the people who are in our clinical ecosystem are humans, and that they are taking care of humans. Rabbi, it's there, and what we were reminded of in the middle, from Stefina. She reminded us that on the other end, in this clinical ecosystem, and on the other end of our efforts, are patients. Patients who are vulnerable, hurting, scared, with acute needs, who are dying and wanting somebody to hold their hand, to heal them, to care for them, and to love them. That's about the only 4-letter word forbidden in the clinical care, and we need to imbue that back in. In order to do that, to take care of those vulnerable, hurting, scared, needy, dying patients, we need thriving, healthy, whole physicians. And it's really, one of the startling things is that the word whole and holy have the same root. These are holy moments when you're dealing with clinicians, and they need whole clinicians to deal with them. So I'll leave you with this. I'll leave you with a quote from Rabbi Hillel over 2,000 years ago. And he said it this way: "If I am not for myself, who will be for me? If I am not for others, what am I? And if not now, when?" So here's to us to do those 3 things. Let's take care of ourselves. Let's take care of each other. I mean, who would have imagined that we still have a PPE crisis, right? It was put in the chat. We have a PPE crisis, creating positive practice environments. Let's create that positive practice environment and relight the fire. And let's keep it burning, and let's keep it burning bright together. Leaders, CEOs, nurses, physicians, physician associates, occupational therapists, pharmacists, if I didn't say that, cafeteria workers, maintenance workers. Together in this ecosystem, we need to do it together because we have work to do. So from here, what we want to do, let's change the world. Let's leap off and change the world. Thank you all so much for coming. Victor, I don't know if you want to say something at the last piece. It was a beautiful day, and it was a beautiful day because of all of you. Thank you.
Tim, there's no way I can say anything more that's more moving and more meaningful than what you and Darrell have done. But maybe if I were to say something, and I already said in my chat, to thank my team who responding to our challenge of doing something in a short time, they pulled it off. It's just amazing. And I think in particular for everyone who's on this webinar, because we're all in this together. And I believe it, and I know we overcome the problems that we face. So thank you very much.
Bye.
Bye.